Very good morning to one and all of you. This might be a little challenging topic to me because I'm a cataract refractive surgeon who do glaucoma work, but here I'm going to play around with the cornea too. So bear up with me. Um, Taking you on phacoemulsification in corneal opacity and compromised cornea, it clearly tells us that there are two challenges. When you're doing a cataract surgery in a patient with a corneal disease, there is a possibility that you would potentiate the progression of the corneal disease, or if you in a corneal diseased eye, you do a cataract surgery, it could actually limit your surgical technique because of the limitations of the corneal problems which are earlier there. So probably something very basic which we can do is, first, if the ocular surface doesn't look good prior to the phaco, lubricate it enough, use punctal plugs if the tear quantum is less. If there is a mild inflammation, ensure that you use topical steroid drops pre-operatively, use preservative-free medications, ensure that you carefully plan your wound location because the cornea could be thin in a particular area with an opacity or a corneal disease, and most importantly, these measures are needed to avoid exacerbations. So taking you through this case, basically, this is an eye with a corneal opacity, and this patient was not ready for a corneal graft. He just wants some amount of visual rehabilitation. So then it's mandatory that we use enough viscoelastic, do a good syneculisis so that you're separating the adherent leukemia from the other areas. And it also makes sense to use pupil dilators, because I think placing iris hooks is not quite a child's play once you get the hang of it. When you're doing a rhexis, try to be a continuous process of rhexis, not lose the rhexis and keep trying to revert back, because the size of the cornea opacity might be limiting. Trypan blue should be injected generously, not just to stain the capsule, but also the cortical fibers. Most importantly, is ensure it's a slow surgery so that you're constantly visualizing what you can in that limited area. You could do a little more than a gentle hydro or a multi-quadrant hydro so that it just tilts up the nucleus, so that it's not exactly supracapsular, but sort of easier because you get better access to the nucleus edge. And then when you place the lens and when the surgery is done, you do realize that you have given some amount of ambulatory vision to these patients, and you should not push yourself away from doing these surgeries. Taking you on further, if it is supposing a dense corneal opacity, you could do a PTK to thin out that opacities to get a visibility, a band-shaped keratopathy, scrape the calcium plaques, and other things which I had already alluded to, make it a deliberate, careful surgery. Now this was a case of a dense opacity, and the patient was ready to do a combined phaco and a PK procedure. So the surgical steps need to be identical, but I did scrape the corneal opacity surface so that some amount of transparency was available as I was doing the surgery. Rhexis, the capsule has to be well stained, and ensure that you do not lose the rhexis all through, and ensure that you do not fluff up the cortex, and so that the visibility is there all through. But in this particular situation, the advantage was I could get the nucleus a little more nearly supracapsular and do the surgery, because there was no need to protect the endothelium, and it was more important that I do not damage the posterior capsule, and then placing the lens, and then doing the routine procedure of cutting the button and then placing a donor button. So the surgical procedure per se, if followed properly, takes you forward. Then again, this is a case of a corneal opacity, and the patient was very keen on, because he had a significant astigmatism. So we all know that toric IOLs have a role to play only in regular astigmatism, but you could play around a bit if there is some amount of regularity in the irregular astigmatism, which in other words, you're debulking the extent of astigmatism, although you cannot correct the whole portion of it. Some better vision of BCVA and UCVA you are able to provide this patient is definitely a way forward. But sometimes you could be challenged because you do not know the exact astigmatic component, so the K values may not be possible in the same eye, the measurements. Try to take the K value in the same eye. If not, try to take the K value of the other eye. But then we need to understand, if it is a younger patient who has had a PK done, that was a previous case, was a PK done. So if it's a younger patient for whom a PK has been done, and you think that this patient may need a regraft, somehow it doesn't make sense to place a toric IOL earlier on, because once you need to do a regraft, basically the toric IOL is just reflecting the corneal astigmatism, and when you remove this cornea and going to place a different cornea, then it may not be possible. But in these cases, instead of a PK, you do a DSEC or DMEC, makes sense. The other big advantage you could utilize is using using an endoilluminator, whether you go through the limbal route or make a transconjunctival injection and incision and go through the pars plana groove. What it does, it gives a backscatter of light, and this backscatter of light, if you can see, of course you need to stay in the capsule and the cortical fibers if you can, but you are able to get visibility. This case was further more disturbing because there was a flutter in the eye, and there was a tendency for the iris to come into the phaco probe. So you need to be even more careful, and because there could be the posterior capsule bouncing up and down. So the surgery has to be extremely gentle, but this endoilluminator would tell you that we are able to do a complete surgery and then place the lens and get away with it. Again, the other challenges, supposing you're doing a phaco in a case of a PK, the challenges are that there could be leakage from the corneal incision, and we need to remember in a post-PK eye, there is pellucid type of changes which occurs in these long-standing grafts, which the peripheral cornea could become thin. So when you do your corneal incision, try to keep away beyond the graft primarily, and ensure that you definitely suture the wound, because you do not want the AC to get shallow, and we go ahead and remove these sutures after 6 weeks. Again, the amount of astigmatism, if it's high, you could always ensure that the K readings from the opposite eye is taken, and you could do a same correction in the same procedure. Again, if it is a DSEC eye, we need to avoid leaky wounds, but one important thing here is when you're placing a DSEC graft, you should remember that there is an increase in the negative posterior corneal curvature. So these patients could have about 0.75 to 1.5 diopter of myopia. So you should anticipate this hyperopic shift and make these small adjustments in your IOL power calculation before you place the lens. Also, we need to remember, if you're using a larger graft, there's a greater hyperopia which could occur. However, the interesting thing which I also learned was the induced astigmatism in a DSEC is less, so toric IOLs are still possible. Again, in a DMEC eye, this negative power coming on from the lenticule is not there. That's a big advantage. The chances of an iatrogenic cataract is also less if you have done a DMEC before you do a phaco surgery. A simultaneous surgery is also possible because it does not compromise on the endothelial graft cells, and a normal IOL power nomogram could be used. In a keratoconus eye, the important thing is incisions have to be absolutely safe. Toric IOLs is possible for the regular component of the astigmatism, and in a severe keratoconus eye with corneal thinning, we need to be wary of wound leakage. I'm just briefly trying to show you the video here. This is a case of Fuchs. We all understand in early Fuchs, you could still do a gentle phacoemulsification, do a soft cell technique, ensure that you are protecting the endothelium to the best possible way. But if the corneal thickness has increased over 640, if the patient has complaints of visual blur and he has early morning glare, these are clear indications that you need to do a DSEC in the primary procedure, and then you score out the Descemet's membrane and place a fresh graft and ensure that you have a tight closed wound. Just 1 or 2 slides left as I take you on. The cutoff point, which I already told you, is 640, and ensuring that your phaco parameters. Again, this is a case of a very bad opaque cornea. Then you could just remove the anterior opaque cornea, and then there is some amount of visibility which is ensured, and you stay in the capsule and do a gentle phacoemulsification. And then you could go ahead and remove and go ahead and do a posterior PK as is shown. Again, if it is a Stevens-Johnson syndrome, you need to stabilize the ocular surface with steroids, artificial tears, cyclosporin, punctal occlusions, use amniotic membrane grafts, do everything which you can do, and then combine it with a careful phaco. Again, if you're doing in a post-herpetic case, a herpes zoster or herpes simplex, it makes sense to start the antivirals a week or 2 before and follow it up to about 4 weeks or beyond to prevent reactivation. So there is so much more that could be discussed about phacoemulsification in the presence of corneal opacity and a corneal disease. But definitely a careful, wary phacoemulsification should tide you over those problems. Thank you.